academics, but also participate, as part of the civil society movements or when as an activist. So in various roles, they have looked at this issue from various perspectives. We hope that this panel discussion or this webinar will enrich our understanding on the political economy behind this NCD declaration. So as all of us knows that this is the fourth high-level meeting related to non-communicable disease, and this is the fourth political declaration starting in I think in 2012, and sorry 2012, and then we have 2011, and then we have in 2014 and 2018, and then now. So the next such a high-level meeting is going to take place after 5 more years later. I think it's 7 more years in 2032, I guess, as per the current version of the political declarations. We also are aware that, so of course, after 6 years, 2031 is the next round of high-level meeting is to take place. We also know that this time, this political declaration has not adopted by consensus. Formal adoption is to take place. This is primarily due to the dissenting opinion or dissenting note circulated by the US, and they basically walked away from the consensus. As a result, the General Assembly has to now vote for this and adopt this NCD political declaration. So against this background, let me also take 1 or 2 minutes to explain the structure of the political declaration. The political declaration, apart from the preamble, is divided into 5 parts, basically. The first part deals with the, under the title, create health promoting environments through action across governments. And second part is the strengthening of primary health care. And third part is on mobilize adequate and sustainable financing, then strengthening governance, and then last part is support research, strengthen data and public health surveillance. So these are the important parts, and it then sets 5 targets under various parts of the declaration. The first target is that at least 80% of the countries have implemented policies and legislative, regulatory, and physical measures to support health objectives related to prevention and control of NCDs by 2030. Then second target is that at least 80% of the primary healthcare facilities in all countries have availability of World Health Organization's recommended essential medicine and basic technologies for NCDs by, again, deadline is 2030. Third is at least 60% of the countries have financial protection. Policies, measures in place cover or limit the cost of essential services, diagnostics, medicines, and other health products for non-communicable disease and mental health. Then at least 80% of the countries have an operational, multi-sectoral, integrated policy strategies and action plans on non-communicable disease. And lastly, 80% of the countries have an operational non-communicable disease and mental health surveillance. So the important feature of this edition is that well-recognized on the issue related to mental health, along with all other issues referred in the past NCDs. We will be unpacking some of these issues in detail, and this webinar is organized in such a way that we will be posing certain questions, and then our experts, panelists, will be responding to those questions. So, Okay. Now, let me introduce the panelists. I think most of you are aware. All these people, they don't require any formal introduction. We have Patty Rundell from the mainly from IFBAN, International Baby Food Action Network. Then we have Fran Bond. So, Dr. Fran is even was a member of WHO's Commission on Social Determinants of Health, and from I think long history of working on these issues, and mainly specializes in commercial determination of health. And we do have Dr. Sundar Raman, a well-known public health expert and part of the People Health Movement, wrote extensively on issues related to various public health issues, mainly focusing aspects like health systems, primary health care, and we do have Nicoletta Dentico. Nicoletta mainly worked on issues related to finance and financing of global health, and also looked at some of these industries' involvement in the NCD space. And similarly, Patty, I forgot to mention that also worked extensively on the involvement of industries in, especially the baby food industry, and conflict of interest arising out of that. She has expertise and extensively looked and monitored these issues. So against this background, now let me start with the questions. So I think I'll ask the first question to Sundar. Sundar, as you know that there are five targets which I read out. So now how realistic is the declaration in terms of these five targets set here, and particularly from a global health perspective, how far these targets are realistic, which can be achieved considering the current political economy environment.
So thank you, Gopa, for having me, and it's an important topic. And to cut just one introductory line before I project these five targets. There is this general thing of non-communicable disease as having either been a problem of the global north and only emerging now after a so-called epidemiological transition in the global south. Nothing could be further from the truth. If we look at age-standardized mortality rates, the mortality rate and the prevalence of non-communicable diseases in the global south has always been higher. The poor suffer more from non-communicable diseases. The fact is, as proportional mortality, they may be dying more of diarrhea and communicable diseases. But in absolute terms, non-communicable disease has always been a major problem and is a major contributor to out-of-pocket expenditures and finance because it has never been financially protected. This is not something of a failure of the local governments or providers. It's policy driven with the structural adjustment program, deliberately saying that we will limit public services to a narrow spectrum of services and leave the rest for the private market. So non-communicable diseases was by policy left to the private markets. And that's what we inherit when we begin this conversation. So now when we are saying that we are actually talking of bringing this under the scope of a program, and the earlier program also came with WHO, though World Bank pushed it. Now we really need to shift a lot of this care from currently being in the private sector passively. It's not an active privatization. It was private sector was defunded and only private sector was providing these services to the public services. And that's a big call. So let me just quickly take you to the games that have been played with these targets. If you ask me, are the targets realistic? I find myself, when I look at these targets, they may have already been achieved. In fact, there's no way in which they can't be. These are written so generically, and in school we had a poem called "The Garland of Precepts," by Phyllis McKelly. We were just said a whole lot of nice, funny, humorous poem with a whole lot of advice that it gives. It's just a set of advice that is given. There's hardly anything that you can really hold it to. There is one paragraph. Can you see this slide now? Can you see the
Yes, yes,
slide?
yes,
Yes,
Sundar, we
yes,
can
we
see.
can.
So if you look at this, you will find that there is one particular. Let me just get that.
Yeah. It's not on view mode.
Yeah.
If you can.
Yeah, it's not on view mode, and I'm having problems.
Yes.
And
Yeah.
you can click on slideshow. Yeah,
Yeah.
fine, fine.
So we find that what are the state committing to? Fast-tracked efforts to accelerate progress on NCD over next 5 years, focusing on tobacco and nicotine control. No doubt, tobacco and nicotine control is important, but here an indication is being given to be very selective about one place where we have a convention, a framework convention, which also means that the importance, it's sort of being selective within NCDs. Second, preventing and scaling up effective treatment of cardiovascular risk factors, not even cardiovascular diseases. And cardiovascular risk factors amongst a whole lot of risk factors, such as hypertension. We're not even mentioning diabetes within this thing. And preventing and scaling up effective treatment of the risk factors. So there's no commitment here to treat cardiovascular disease. There's no commitment to even prevent it in an effective way. It's an effective treatment of, and improving mental health care with the aim to reduce by 1/3 premature mortality from non-communicable diseases. This keeps to the earlier statement, and achieve the following global targets. 150 million fewer people are using tobacco. 150 million more people have hypertension under control. 150 million more people have access to mental health care. These are largely unmeasurable. Only 1 in 7 in most of India, it's about 1 in 7 hypertensives are detected. Most of the others are latent disease. They are hypertensive, but they are not detected. In mental health, it may be anywhere from 1 in 25 patients of depression with clinically significant depression are detected. Most people are foregone care because of latent illness. They manifest only when there is a stroke, a hypertension. It as a target, as a system, and it also going to. So if I go back to what is happening, because I look not only at India, but in the entire South Asia, what we have seen in a number of programs, I've been visiting these countries and looking at the primary health care program. What you have seen is over the earlier primary care package, there is a notional addition of hypertension, diabetes, and a little bit of screening for cancer, breast and cervix and oral cancer. Little bit, it's about very low percentage, but at least at policy intent. We really have nothing much more going to go through it. So when you then look at the 5 sets of targets, at least 80% of countries, that means all the global north is included, in which have already got universal healthcare is included. So what would be the progress in the south? We really don't know. Implemented policies, legislative, regulatory, and fiscal. By definition, we all have policies. We can't but have policies. So the question, are there laws? There are some sort of laws. There is effective public health laws or very few, but certain laws to regulatory measures to support health objectives related to prevention of non-communicable disease and promotion of health. Almost what you call a non-falsifiable statement, meaning non-scientific in that. You can't say it's not there, it's somewhat there. And 80% of countries have that. And which countries, the 20% will all be the countries which perhaps require that the more. That's a very weak statement. If you look at the content of this, there are 8 precepts, advisories that are given. We can't say this as more than advisories because it just uses promote, prevent. We must note that on social, economic, and environmental determinants, what advice is being given is good stuff. But it's advice. So poverty, hunger, education, social protection, exclusion, it's listed. In tax and tobacco control, there is much more specific information that is given. That's good. because that's where they are serious, and you can see that that seriousness is reflected in some things which are falsifiable. We can go back and see, did the country did it? And if they say we did not do it or we did it, we can say, look at them and say, oh, you did not do it because you said that. But if you look at, say, something like mental health, the entire focus is on preventing suicides, and two things like helplines, mostly not going to be effective. No understanding even, we shall have a discussion about, that's the wording of what it is said. We shall have a discussion about some of the determinants. That's what you're committing to having a discussion on some of the issues on that. And in aging, the rest of that is really sort of vacuous advice on that. There's a serious lack. And we must remember that in the South, the global South, I suppose it's there in the global North also, beyond tobacco, alcohol, the entire social determinants, societal determinants in terms of employment, the precarious nature of employment, the consistent exposure to violence. We're not talking only of violence victims. We are talking of the continuous threat of violence under which whole regions, societies live. These issues are huge causes of non-communicable diseases and mental health. There's absolutely no real mention of these as factors in the mental health area or even in the non-communicable health area on that. And a very weak mention in one place of commercial, but on the whole, absolutely no focus on commercial determinants. So absolutely. You come to the next target, strengthen primary care.
Sundar, we will come back on in a much more detail.
Shall you give me just one more minute? I will just wind this up.
Yeah.
Strengthening primary health care. Again, the issue is we have really got selective primary health care. And again, that having essential medicines is the least of the problems. It is a major problem. Having a workforce out there or even having any access to primary health care is what we are struggling with. In adequate and sustainable financing, the target is 60% of countries have financial protection. By definition, today in India, we have such policies. But in practice, its implementation, it's not just an implementation, the policies itself are so inadequate that we would be wondering whether it should be consistent with achieving anything. Strengthening governance, again, 80% of countries have some operational integrated policy or action plan. These are, and if you look at the details also, they are very gratuitous, generic statements followed by that. So most of these countries can very well say, look, we've adopted a policy, and there is no commitment which says there is a policy intent. There is no understanding. So the biggest problem is many of these precepts have always been there in our understanding. Any serious document would have struggled with why have we actually worsened on all these parameters and what can we do better, and where have we in the last 15 years since the first thing not been able to get on board. And that we find is completely missing. There is no critical understanding of why financial protection is actually worsening over the 20 years in many of these areas, why non-communicable diseases continue to rise despite a widespread understanding or some formal policies already in place in many of these countries. So I think it's a very inadequate, non-serious sort of political declaration, which is a sort of status quo, in effect, a status quo statement. I mean, we are happy that we are still able to continue talking about it, but that's about it. Thank you.
Thank you, Sundar. That takes me to the next question to Nicoletta. So there is already a reference on the on the social, economic, and environmental determinants of non-communicable disease and mental health. There is a clear reference in paragraph 42 of the declaration. So the how far these measures suggested in the political declaration effectively address these determinants, or is it again kind of a very broad statement in a way reinforcing the status quo, or is there anything give us optimism and ray of hope?
Thank you
Nicoletta,
very
please.
much, Gopa, and thank you for inviting me to this very important conversation on NCDs in the context of the political declaration. I am afraid that I need to echo some of the comments that have already been made by Professor Sundaram, because I think overall, and this is not the first time, and this is really more and more the kind of literary regime of the WHO documents and the UN documents overall, list of good intentions. Actually, it's a catalog of good intentions that have no dent, no biting, no prospect of real implementation. I mean, rereading this declaration, I mean, the sense of this growing 80% nightmare, is because by 2030 is kind of mounting, increasingly mounting. Now, of course, you have to make a reference on the social and environmental determinants of NCDs. It's impossible to think that you cannot, make a reference to the fact that many NCDs are related to air pollution, the quality of air pollution, the quality of air, and therefore pollution, environmental impact of energy policies. There's among other things, and I mean even looking at perhaps even mental health, some forms of mental health are closely related to the fact that in urban areas there are no trees, there's no real green, there's no, the enabling context and enabling environment for a person to live in a state of well-being. However, it kind of glances upon it. It gives a glance to the problem, but then it doesn't really call the problems. It doesn't really define the problems. It kind of pretends that the WHO and the UN have this broad encompassing view. But then when it comes to the resolution part or to the prescriptions part, if you like, even in this segment of the declaration, it goes to looking at basically biomedical solutions. And it doesn't mention which of course are important, but they would be even more important and more effective if we worked on the biomedical access to medicines, access to diagnostic part, with a serious work on how we can seriously avoid these non-communicable diseases, how we can look at from an environmental perspective. But of course, it's also the environment for me is even linked to the food we eat. There are entire populations that are actually, feeding themselves on toxic food, starting from the use of herbicides, pesticides, which are at the origin of vast escalation of cancer in the world. The latest study, for example, that was published last May, the first global study on glyphosate use and cancer, has demonstrated with no doubt that the use of glyphosate, which is the most widely used herbicides in the world, is leading to a wide range of cancer. So, and it also produces other genetic diseases. So, I'm speaking from Europe, and Europe has only in November 2023 renewed glyphosate use for another 10 years in a decision that was completely bypassing all scientific standards, all protocols and procedures of a sound scientific analysis of this herbicide. And of course, now you have Pesticides Action Network taking a litigation to the European Commission for having been completely pervaded and influenced by the lobby of the big chemical industry. So when we talk about GOPA, the environmental determinants, and of course the social determinants with them, we are really covering a huge, wide spectrum of interconnected factors that the policy declaration, that the political declaration doesn't even mention. It doesn't even touch upon them. So I really doubt that, yeah, exactly as the previous speaker was mentioning, there is any sense of a journey that leads you to a certain kind of identifiable horizon. You have this kind of huge, totally unrealistic number, 80%, with a totally crazy timing, 2030. We are already in 2026 soon. For me, it's, you know, it's this kind of literary exercise whose capacity to really bind politically governments is extremely ephemeral and vague. I think it's really, you know, it's not what the world needs. It's not what countries need. It's not this way that the UN can get its own credibility at this very critical moment of its existence. I think it's also a kind of a geopolitical issue when we look at specific items through the lenses of already packed sentences, frameworks, interpretative keys that lead us nowhere. And this applies also, maybe we can talk about it later, with the financing for this, you know, and it's really non-committal, let's say, non-committal.
Thank you, Nicoletta. Now let me move to Fran. There was a clear reference on the all important determinants of NCDs, and Nicoletta already focused on the environmental determinants. Now, could you explain the main commercial determinants in the context of NCD, and also how far this declaration address those issues? And is there any kind of ray of hope on the way in which the declaration deals with these determinants? Thank you.
Fran,
Dr.
you're muted.
Yeah.
Sorry. Thanks, Gopal. And it's lovely. Good evening, everybody. And it's lovely to see so many comrades from the People's Health Movement online. So it's great to see you. I'm afraid I can't give you a ray of hope, Gopal, on this one, on commercial determinants. You know, I mean, commercial determinants are blandly are just the pathways by which commercial factors influence health. And I'd see, in terms of NCDs, that's two ways. One is the products that a lot of commercial companies produce, particularly big transnational corporations, alcohol, ultra-processed food, promoting gambling, alcohol, and so on. So there's the products and fossil fuels, of course. And I think we all know the pathways. I think just I think there's been an analysis that ultra-processed food, fossil fuels, and alcohol contribute themselves to about 40% of NCDs. But then I think there's also the practices of particularly transnational corporations, where they'll manipulate science to say, well, you know, ultra-processed foods isn't really bad for you, for instance. There are other practices lobbying governments to ensure that the regulations that we would really need to influence NCDs, those regulations don't happen. And the other practice is they massively spend on advertising unhealthy goods, and that's not regulated. And of course, increasingly, and this is really Nicoletta's point that she talks so well on, but the whole financialization of the economy is a commercial determinant of health. And that's driving a lot of the privatization of services that mean that they're not meeting the needs of people who have that disease. I looked at what does this declaration, you know, it's a political declaration, and it doesn't mention commercial determinants of health, which is fairly amazing. It talks about poverty reduction, but doesn't mention wealth reduction. I think one of the most pressing commercial determinants in the world at the moment is the massively growing wealth inequities. And that, for me, is the most basic, that we have this unfair economic system that's based on extractivism of wealth and resources from so much of the world to rich countries, particularly the US. And it just doesn't mention that. You'd think we had a sort of level playing field economically, which of course we don't. And increasingly in our work with my research group, we're using the Marxist concept of alienation to look at commercial determinants of health, and looking at how people are alienated through processes of production, whether that's poor employment conditions, gig work, or all sorts of ways in which employment conditions really affect people. And that, of course, leads to many non-communicable diseases, whether it's through mental stress or people having to do terrible working conditions that creates heart disease and so on. And then I think consumption itself, obviously the consumption of the unhealthy foods that are being increasingly pushed in countries around the world. So instead of people eating healthy food, they've got all this advertising. But also in the frustration of dealing with large corporations, I think that really affects people's mental health. And there's been lots of examples around the world. I mean, I think indigenous people have suffered so much from the extractivism of mining companies, and that's led to a whole lot of non-communicable diseases. Just one example in the US, the British Post Office scandal, where people were totally ripped off by Horizon IT, caused many suicides, people to have huge mental health issues. So I think the behavior and practices of these big corporations are becoming a major risk to health, but you would never guess it reading this political declaration. And it really, really doesn't come to grips with what commercial determinants of health are really. So, I would have wanted to see it naming the unfair economic system that enables corporations to act in the way that they do, to talk about how there can be better regulation, to talk about how excessive wealth creates societies that breed NCDs. And we know in just about every country, economic inequities are growing and they fuel health inequities. And then I would have hoped it would have said, well, what would be a kinder economic system? Is it cooperative forms of production? Is it, for instance, to take the issue of food? Is it indigenous food production rather than massive agribusiness? What would be healthier? What is a healthier economy? What is a healthier food system? So I think it's very disappointing that it really doesn't tackle commercial determinants at all, really, or look at those sort of this underpinning global economy that is driving so much of these NCDs. So I'll stop there. I think I've had my 5 minutes.
So thank you, Fran. And so all these, commercial, social, and environmental determinants are mentioned in the first operational part of the declaration, those who have not looked at the declaration. So from there, let me take to the very last part of the declaration, that's under the subheading called follow up, where Patty, this question is to you. The declaration actually calls upon the participation of the private sector, and it says that the private sector to strengthen its commitment and contribution to the prevention and control of NCDs, taking into account the need to prevent conflict of interest. So, having worked on this area for many years, and especially focusing on the work of WHO in the area of especially the marketing code, the implementation of the marketing code, and also in the NCD context, how far WHO succeed in able to manage this conflict of interest in dealing with the NCDs context, as well as is it a kind of a real firewall they are saying to manage the conflict, taking into account this conflict of interest in the declaration, or is it kind of a call in a way to remove that firewall and allow the private sector to be active, in the name of NCD prevention, and to pursue the kind of, they're using NCD for in the pursuit of profit and further advancing their commercial interests in the name of controlling or preventing NCD. So could you throw some light on this issue? It would be grateful.
Thanks, Gopa. Yes, and you've been alongside us together on this long journey. And in fact, a lot of people have been asking me, well, what's the actual nature of why is it any good to have a political declaration? As I come from IBFAN, which has been working, as you say, since 1980s, 1981, when this code, the first tool, real tool to give to member states and so all governments and to health workers and consumers, a tool that they could bring in to stop harmful marketing. And this is really the first of its kind. And since 1981, we've steadily tried to bring that into law in every country. And that is something that has teeth. And it's actually, when Nicoletta's saying this has no teeth, it has no teeth. You know, it's not as, the declaration doesn't seem serious in really helping governments do what they need to do. And they need to tackle that whole idea that the corporates, particularly the international corporates, maybe your small local farm shop or whatever will be fine. But what we're dealing with is the major food corporations that deal with mainly ultra-processed foods. They're mainly you know, in our issue in nutrition and whatever, it's at Codex. So they're setting standards that literally put a limit or make it very difficult for countries to really bring in the legislation that they need based on what WHO and the World Health Assembly has said. These are really excellent tools that governments can use and actually, you know, bring it into law and follow those companies, hold them accountable, monitor them, and actually do something about the harmful environment that is changing cultures and making people feel that they must do this. This has all been done through the back door at WHO, and I'm so torn because WHO has really tried in recent years, certainly in the last 20 years, and did in the 80s, really tried to bring in sort of support to member states to look at and prevent conflicts of interest. But you know, 2002, that's when, you know, the NCD global strategy was passed. Then you had 2011, the first political declaration. It wasn't, you know, that's when you had a conflict of interest right in the heart with NGOs that were set up by industry. And I'm not going to mention names, but they were set up by a million. They were the bingos, we call them business interest NGOs, that we fought with in 2011 at the first political declaration. And they did not want conflicts of interest in there. So all that mealy-mouthed language of where appropriate or this, that, and the other, the whole thing was just watered down. And that's when and the same 2002 was it, or 2003 with the global strategy, it's got the partnership language in there, and that language really makes member states feel that actually these big corporations, if you partner with them, you can get in the room together and talk about them, and they'll suddenly change, and they'll incrementally change. And they can do the outreach and the education. They can do all this. It's nonsense. We all know it's nonsense. And I think now many, many NGOs wouldn't go anywhere near corporates, you know, that are selling ultra-processed foods or tobacco or whatever. They would know that that's a conflict of interest. But it was very difficult in the 2000s and in the things. It was really hard. We had a multi-stakeholder approach. You had Global Alliance for Improved Nutrition, World Economic Forum, heavily involved in the political declaration, SUN, the Scaling Up Nutrition, all saying this is the way forward. Bring everybody under the same umbrella. Don't have conflicts. Don't have all this. Bring us all together, and they will change and really help. And it was all predicated on that idea that you would deliver these nutrients to everybody. But they were all ultra-processed foods. I mean, really, in order to deliver these extra nutrients, You had to have a package, you had to have something. So it was going right away from breastfeeding, from family foods, and just mashing up a banana and giving it to a baby, or growing agroecology, all the things that the NGOs wanted. This was a different approach. And that is the big fight, it seems to me. This is really important that, and I feel for WHO because it's under such pressure, but it's still, until it sorts out its own conflict of interest policy and extends from just tobacco and arms, isn't it? All these other ones can come in. On our issue on infant feeding, they've been very, very careful and, for what they say. We certainly don't have the big baby food companies aligned with WHO. We had a meeting with UNESCO yesterday. UNESCO is doing a joint education policy with Nestle. And we had to say, this is just not on. You can't have your names next to Nestle and educating the future children of this world. So, this is the political reality we're dealing with. The same in the UK. They have a 10-year plan where they're saying, oh, yeah, we'll partner up. And as long as these companies are genuinely wanting to protect health, this is just nonsense. But, since when is a multinational corporation that is spreading ultra-processed food, going to be able to genuinely want to protect health and sign up to all these high ideals? It is a nonsense. Not that we're wanting to demonize them, well, sort of slightly want to demonize them, but I'll leave that aside. But what we want to do is be realistic about what their roles are. They do not have a democratic responsibility to look after any of us. That's not their job. And I really wish they had done a little bit more on the safeguards and due diligence and help help member states really see that they should take care, actually put the work in to check what's going on and what these companies are doing. And I at the moment it's not there. Okay.
Patty is a sort of follow-up question. So you said that there are these corporate forces are working and their agenda has been kind of got mainstreamed as part of the NCD agenda. So, but ultimately, it is the states have to own up these ideas, right? And so how these dynamics play, if you have any insights, and also how this kind of approach in a way act as a barrier to the real change. So if you can,
I think it does.
if you can shortly answer, then we can move to the next.
Literally, I've just been discussing with the political parties here in the UK. This 10-year plan in the UK is all predicated on partnerships with the industry so that they do the work of educating. I've been talking to all the policymakers here at the thing because I say, how can you do that? You need to do your work to look at whether Danone, for example, they're saying, oh, well, Danone has offered to reduce the sugar levels. And they promise that they will never produce a baby milk. And I think, for God's sake, they have all these growing up milks that are just very sweet. And you're just saying that they can do, so they will go online, they will be bombarding parents with all terrible things, but maybe they will have a reduction in the sugar levels. This is nonsense. And so that they need to spend more time actually doing the due diligence. And I think we as civil society and NGOs need to help them and point it out to them because they don't have that time, or they're certainly not spending that time. And I think because I genuinely think that many in the government want to do the right thing, but they don't realize that the companies are actually taking them for a ride. They know damn well, what they're doing. And so we need to just channel that in the right direction, have really serious, and WHO has its own guidance, which is produced for, and you know, for member states, guidance on how to interact and what due diligence to take and how to make sure. You know, it was hard to get that to be as strong as it is. And it still talks about partnerships, which I think all of us around this table, we think that's a nonsense. How can you partner? How can these corporations are far bigger than any of us and are totally different. You don't partner because partnership involves, you know, it means governance, and it means that that entity can be involved in the governance. And it's just a nonsense as far as I can, and the word stakeholder. I mean, I can't stand the word stakeholder because that means we all have a stake in this. We don't have a stake in it. I say sometimes I feel we should be left out because we don't have a stake in you know, NCDs. We don't, but an industry does. So does that answer your question?
Yeah. Thanks. And sort of this WHO's guidance, as far as I know, is how to deal with the conflict of interest in the context of food and nutrition, but it's not applicable to the entire NCD. And
No.
also what you said about the partnership. So I would also like to recall the kind of parallel made by Jonathan Marks in his book on perils of partnership. He said that,
Exactly.
look, in democracy, we do have the concept of separation of power. We don't want judiciary and executive and the legislature to work in in partnership because certain firewalls are required. So similarly, we can always talk about efficiency, but certain partnership in the name of efficiencies should be prohibited because that brings certain kind of interest which brings this risk of undermining the public health. So
And
with
confusion.
this.
Yeah, total confusion in people's minds. They don't know, and they're presented with this entity in the wrong place. We shouldn't really be demonizing. We should just say this is what they are. A corporate, you know, is what it is. It has its own job to do. Don't let's mess it up and start bringing them into the governance and with partnership language. And you know, it really seems, you know, very unwise. Okay.
So thanks, Patty. And let me move to Fran. Basically, the paragraph 43 deals with the on taxes and a clear reference to tobacco and alcohol. There was a talk about, many people were talking earlier and now also talked about the sugar tax or soda taxes. They are missing from the text right now. And there is also a view also that tax is that an effective tool to deal with these health issues. How far it is a tool. In the fight against NCDs. So if you can throw some light on these two issues, it would be great.
Yeah, it's an interesting one because tobacco taxes have been effective in countries. I think evidence suggests that a 10% increase in prices reduces consumption, but certainly in Australia, we're finding we now have a big illegal tobacco trade anyway. So that suggests that people can get around taxes. We have very high taxation, and you know, we've seen in Thailand that they've shown that tobacco taxes lead to larger health gains because amongst low-income people because of high quit rates. But the problem is, of course, that those kind of consumption taxes are quite regressive. So, you know, if there's a 50-cent tax on a bottle of soda and you earn $2 a day compared to someone who earns $100 a day, then it is very regressive. But probably, you know, given that in most settings, lower income people are more likely to consume the drinks, then in the long term, probably the health gain would be there. But in the short term, it's a very regressive tax. And certainly the Mexico example found that poorer households were more likely to reduce their purchases of the soda tax. So that, you know, overall, I'd say they're probably a good thing having these taxes. But I would say more importantly, there needs to be, you know, progressive taxation in the country that can actually pay for a whole lot of the services that people need, and and the, you know, the political policy doesn't really deal with that. It just talks about these very specific taxes. And I mean, I generally, and I pick up on what Patty says, generally there's no power analysis. I mean, it's bizarre, isn't it? We've got a political declaration that doesn't talk about power. So it talks in one sentence about NGOs, governments and corporations as if there's somehow equal power there, where of course they're vastly, vastly different. And yet, if you read the declaration and you arrived from Mars or somewhere, you'd think that all these groups had exactly the same power. So I mean, I think the health taxes certainly can be regressive in the short term, but I think the most important thing I'd want to see in a political declaration is to urge countries to see that proper progressive taxation on wealth, especially on making you know, there is a process to try and stop corporations evading tax, which they do all the time. There's a major industry with all these big consulting firms to minimize the tax of wealthy people and corporations. And I think it would have been much better if the declaration had talked about that, because it suggests lots of areas in which governments need to spend money, you know, whether it's on health services, whether it's, you know, on different ways in which they might treat and prevent NCDs, but it really doesn't look at, well, how are governments going to fund this? So, you know, I think taxations are a crucial public health issue that we don't pay enough attention to as a public health movement, because, you know, our Council of Social Services in South Australia ran a brilliant election campaign where they said, without taxation, vital services disappear. And that's the case. And I think we need campaigns to show people the value of taxation, particularly to poor people. You know, wealthy people should be paying much more tax, and yet they can consistently avoid it. So, you know, I think health taxes can be, yeah, they are regressive in the short term. They might have some long-term benefits, but I think the big issue on taxes is public taxation in general.
Thank you, Fran. So basically, it's a very important point that this declaration is very silent on like a progressive taxation, especially the corporate tax as well as on the wealth tax. So that takes me to the another issue related to again on the financing part of the NCD. That's the question is to Nicoletta. So could you help to understand how this debt repayment and broader physical justice issues intersect with the NCDs, and especially in the context of, you know, universal health coverage? So we know that many times, you know, especially in the global South, countries are facing this kind of debt crisis, and the immediate cut always happens on the social sector, including health, and this sort of even on labor rights, wages, and then it's a kind of a cascading effect on including on health. So could you explain us how this debt issues is coming on the way, and is there any reference on debts in the declaration?
Thank you, Gopa. No, unfortunately, there is no reference whatsoever, not only to debt, but to any other financial injustice that rules this world, and which should be there, because the text of the declaration in the paragraph, in the section that relates to financial protection and financing for NCDs, is once again a repetition of, I think, an ideological approach to health finance. And I want to be slightly provocative here. I know that we may not all agree with this, and then I'll come to that. But, you know, the idea that you can finance a typology of disease area like NCDs through ODA is to me kind of ludicrous. not because I think this ODA, and I'm saying it from a global north perspective, is a trap, is a real trap, as we see it now with, of course, the brutal, sudden cutting of ODA, not just coming from the US, but also from many other countries in Europe. So why don't I think that ODA is the solution? Because it actually, is totally in a position of disequilibrium. It corresponds to a narrative that doesn't hold. Let me explain. This idea that donor countries, the countries that donate the money, you know how much they donated in 2022? The ODA to the Global South was something like $320 billion, according to the World Bank. Well, the enormous amount of money that the Global South donated to the Global North is incommensurably higher. It is $9,957 billion. So how are we going to play as NGOs, as civil society, with this financial discrepancy? It's an abysmal trap. And I think, and this is a self-criticism, that we have accepted for too long the idea that whereas in Australia or where Fran lives, or in England or in Italy, we have universal public health systems financed precisely with what Fran was saying earlier, a progressive tax fiscal system that actually allows the poorest not to pay any taxations, because it is the wealthiest that will cover for those who cannot, okay? And the public health system is free of charge, not because they make you pay according to your budget, but everyone has to go freely to, get assistance, because the payment comes through the fiscal contribution. So we have believed, and we have created institutional welfare setups in many countries, and we have just bought the assumption that for the Global South countries, it should be another way. It should be through ODA. It should be through charities. It should be through funding from the Global North. Now, I believe the Global North has a lot of money to give to the Global South. Don't get me wrong. I think there is a lot of work that needs to be done in this area. And here I come to the debt issue. Debt, together with illicit financial flows, are a kind of a Marshall Plan from the South to the North. This has to be broken. I'm sorry. And if we don't start doing it in this chaotic moment where everyone, everything, the building is collapsing, I think we're going to make a major strategic mistake. We need to break this cycle of the debt repayment. During COVID, 24 highly indebted countries in Africa could not invest more on COVID because of not even the repayment of the debt, is the repayment of the service of the debt, which actually eats up, for example, 39% of the GDP of Uganda. So we need to change the narrative completely. I perfectly understand this is not an easy thing to do, but we really need to reset our narratives and our arguments. So when I see a declaration that basically relies on ODA, and when as a way to go for reducing mental health and having financial protection, and then it talks about voluntary, innovative financing mechanisms and partnerships, including with the private sector, this goes hand in hand with the ODA. So we need to really understand. I mean, yesterday, sorry for this, yesterday I had a meeting with the European representative of the World Bank, and he was basically saying that they are going for a new playbook when they even use our concepts, I mean, even our concepts as feminists, the economy of care. They want to create the economy of care, which is actually covering 1.5 billion people with universal health coverage in the care economy through mobilizing pharma, philanthropists, and the investors. I think this is unbelievable. I mean, the economy of care, if I think with my feminist background, associated to pharma, philanthropists, and an investor, is a kind of oxymoron, it's a contradiction. It needs to change. So we need to really work politically with countries. We tried to do a little bit of work during the pandemic treaty negotiation, because in a way, the financial aspect also shapes governance. The governance of the pandemic treaty, the governance of the political declarations we made. So we really need to reframe and to start rethinking. Moreover, and this is my last sentence, as a person who lives in the global north, we are indebted towards the global south. And here we need also to correlate things. We have a huge environmental and ecological debt to the global south. So if there's someone that has to pay, it's us, but not through ODA. It's actually through financial justice. And I think this is the way to go for NCDs.
Thank you, Nicoletta. Now we will have two more questions, one to Sundar and then to Fran, and then we will open the floor for discussion and further questions and clarification. So if both of you can sort of respond to the questions in another 3 to 4 minutes each, that would be great. So Sundar, when we refer to the primary health targets, I mentioned that we'll come back on this issue. The health system aspects all covered under a subheading called strengthening of primary health care. So how far does this declaration go in actually strengthening primary health care? And if you could also compare this, with the WHO's instrument in the Alma-Ata Declaration or an Astana Declaration, how far this current version of the political declaration take into account these two documents?
So, in terms of saying that these services are required, they have restated the obvious. Okay, why at one point historically anybody had to withdraw these services, or now to say that they are required is the issue. There's no-brainers to say that you require screening for cancers or cardiovascular disease or lung health is important, when you know that lung health is about the second commonest cause among the non-communicable diseases and among all diseases of death in the global south, in very high proportion. So you don't need to actually state that. The real thing is what is not stated. What is implicit in primary health care is that these are necessarily public providers. Public provisioning, because it doesn't work under market mechanisms, because the emphasis is on preventive and promotive care. There are very few, in fact, no real major countrywide model of primary health care with that spirit or sense that can be done by any form of strategic purchasing. Even the large-scale introduction of publicly funded health insurance in the global south, post the universal health coverage discourse, is largely related to secondary and tertiary care. That too, very small bits of it. You don't have any system that can do that. So what you are talking is of extending public provisioning of healthcare services through an extensive primary healthcare network, which can be decentralized ownership, it can be centralized ownership, it could be but some form of public financing required to do that. Which means your entire human resource policy, your entire organization of healthcare services needs to match that. You have 1 million community health workers in India, but if you are looking at them for some immediate promotional avenue, it's one thing. But if they are part of our commitment to providing universal primary health care, then they require to be accepted as part of a regular workforce. And you actually require that sort of thing. There is some emphasis, and we can cheer about it. There is some recognition that the Doha Declaration has been sort of re-endorsed. There is a notion of transfer of technology, which is linked to public financing. All the rest of it is voluntary. assess public financing. If there is public financing, there should be transfers of technology on certain terms. And there is something on that. But eventually, the point is, even in the WHO paradigm, what you are seeing is these few more verticals being added on. And that is really not the way to go on that. So the overall strategy on primary healthcare within the UHC bucket is actually very poorly planned. And this whole best buys approach, choice approach, so much nonsense, we can't go into the detail. You really require to look at the deployment of human resources, the expansion of primary health services to meet the requirements, and it has to be done with an expansion. I think this is the main issue on that. I think we've not had time to look at what is happening with the Trump issue, but maybe we will look at that. But basically what you're saying is, this is nowhere near the spirit of the Alma-Ata Declaration, which really sees this as something that has to be necessary. So in that sense, primary healthcare is a public good. And universal access to primary healthcare is a part of your realization of the right to healthcare. This is the particular institutional arrangement through which you can exercise the right to healthcare. So it has it is a certain relationship between healthcare providers and provided. It has a certain role for the community in it. It's not, all of this is not really even envisaged in this document. What you have is a certain set of verticals that are being promoted. Within that, where you have vaccine opportunities, like you say, or cervical cancer, HPV vaccines, or liver cancers, then there is a certain larger delineation of what needs to be done. But in terms of even an understanding of what primary health care is needed, I think there's a much more distance that this is particularly in the WHC. You can see very clearly that the primary healthcare division and the division handling UHC is not coordinating with the division handling non-communicable diseases. The non-communicable diseases continue to be talking of different strategy for individual diseases, some of the diseases more so than others, that are not aligned with the strategy which is on primary healthcare. And part of the reason is that strategic purchasing of any form of major provisioning of primary preventive care through the public sector, at least in to the private sector, at least in third world conditions, is a non-starter. It happens in private markets, they fill the gaps, but they don't actually, they are mechanisms of coping, but they are not really mechanisms of provisioning. So we won't get very far with this. At best, we will have a patchy introduction of hypertension and diabetes care as a result of this particular thing. That's about, and some screening, which is really the screening disasters we hear from the global south. I'm witnessing these. You have many people with suspected cancers. They are sent up to higher centers. There are no centers to manage them. There is nobody to guide them. They go from pillar to post in search. And even if you detect it early, by the time treatment is established, it's too late. So you do have, for example, in India, the incidence of breast cancer is significantly less than in the West. But the mortality rate for breast cancer is significantly higher than in the West. So in absolute terms, per 100,000 population. That really demonstrates as an example of how primary healthcare is itself a social determinant, access to primary healthcare. And that's a determinant that has really not been available to us.
So thank you, Sundar. That takes me to the last question that's to Fran. There is a target related to the financial protection in a way to protect people and also facilitate access. So the target basically reads like this: at least 60% of the countries have financial protection policies or measures in place that cover or limit the cost of essential services, diagnostics, medicines, and other health products. And it goes on. And this target is to be achieved by 2030. So how realistic is this? And this, in a way, kind of again reflects the market-oriented UHC paradigm. So if you can unpack this issue for us, it will be great.
Gopal, I don't know whom you're addressing it to, but I may
I to
quickly
Fran,
come in.
Fran, but you can also make a reference. Yeah, but you can make it short.
Yeah,
No, my
well,
one line. Yeah, okay, Fran, you go
Yeah.
ahead.
yeah. Well, I think really the issue that Nicoletta was talking about lies at the base of this, because if there's all these financial flows from the global south to the global north, then for most people it's going to be really hard for countries to be able to achieve that. And that goes along with the idea of taxation, that, you know, particularly of corporations who are extracting resources from a country and yet paying no tax there. I think it's also, you know, it doesn't deal with the massive privatization of health services that is happening around the world. And, you know, part of that is like private equity funds around the world investing in both care services and health services. So, you know, I would say what we need is a publicly, you know, until you get publicly funded and provided services that are of good quality, and you get a system that doesn't just talk about universal health coverage, but actually talks about universal health care and has the sorts of primary health care that Sundar was talking about, where it actually thinks about social determinants and equity. It thinks about the risk of both medicalization, because I think there are risks of over medicalization too, because in a privatized system that happens, and under medicalization. It's a bit like the nutrition, you know, you've got both going on. You've got too much medicalization because people want to make money out of it, but you've also got this massive commercialization and talking about private sector partnerships that were. And I noticed the declaration talks about alma ata and the Astana declaration in the same view, whereas they're very different. You know, alma ata talked about a new international economic order, which I think is the things that we're talking about. And, you know, that if people are going to have financial protection, then there has to be a whole lot of governance of any private sector provision. And there has to be, you know, a political will that's strong for a strong public health sector that will really protect people and will be based on community participation and political commitment, and put money into prevention as well, and do the sort of I mean, the declaration talks about health in all policies, and that's good, but then it goes and talks about the private sector as if it's just a benign partner who can come into this kind of health in all policies. So I think if we're going to offer people financial protection, then we have to stop those financial flows, we have to tax corporations, and we have to have the real vision of primary health care. And for those of you who don't know about the People's Health Movement, I've just put a link to our charter in there, because we lay out a vision that was written in 25 years ago, but it's still what would, if it was really enacted, would give people that kind of financial protection against the costs of NCDs, and hopefully would prevent them coming along. But until we have a health system like that, I don't think the aim is going to be achieved. If anything, because of the massive privatization, it could go backwards, which I think one of the questions has pointed out, that the situation is actually going backwards, not getting better.
So, Gopa,
please, Sundar.
the point I had to say is this target is a tremendous dilution of the goal. Before, at the start of the UHC Sustainable Development discussion, we were talking of the elimination of catastrophic health expenditure, the elimination of impoverishment due to healthcare costs. That's what financial protection should mean. Not that you can get some discount for the services that you are providing. This is actually what is being talked of now. Limit essential medicines, the cost of it. Limit. I give you a 20% discount on some of these services if you are a thing. And this is actually what is happening. I'm not really saying this because this is something that is thing. And limit that cover, or limit that. All you're asking is for a nominal coverage and a nominal limitation of cost. Whereas what we were really talking of is really that you shouldn't have financial, that the definition said no financial hardship. He's not talking here now of financial hardship. And in most of these situations, limiting costs has no real meaning on this. So extreme dilution of target, and 60% of countries. And at some point, what does it mean to say 60% of, how does UN set a target like, what will it be doing in the other 40% of countries? No, what does it mean to actually set a target like this? This target is a non-serious attempt. It's a cover-up. It's somebody who is saying, look, nothing is going to happen. Let's put it in a way in which we can say we've achieved it, in some way in which we can say these countries have achieved it. Now, all they'll have to do is to pass some resolution or make some enactment somewhere on that. It's very non-serious. But there's a larger issue of which we must understand about what is happening with this whole Trump thing. You know, what we see obviously is that the WHO is defunded and the US is retreating. But when it is retreating, its justification for retreating and not signing this declaration, which I think is an important point, is that we are not agreed with these Raja values of diversity, equity, inclusiveness. DEI is what they are against. But DEI is the UN Charter itself. It is in some sense the whole spirit of being in an UN agency. Now, what does it therefore mean when they are out of that? And why are they doing it? How does it relate? How do we understand something like what the US is doing internally, the MAHA policy, the Make America Healthy Again, the complement of MAGA? In one sense, there's an articulation against corporations and ultra-processed foods. But what you really have is a sharp cut on Medicaid, your understanding, undermining of public health institutions, and public support for vaccination programs, not vaccination per se, but public support and the veterinary hospitals for that. I think somewhere what the US is saying is with gloves off, we are against any, healthcare is far too profitable an area, far too a major part of our GDP comes from the healthcare industry, and we are at war with any form of public services anywhere. And therefore, the WHO, which was a promoter of this, is being actually defunded as a thing. You remember when the essential medicines policy was introduced, the US started its first defunding act on that. It was not directly connected. But at some point, they found that in that the writing of the wall on that. And this is what they are really saying. So you see the latest thing, the UK, for example, is going to withdraw its value for money policies with the nice thing so as to pay more to pharmaceutical companies. So this is setting in place an overall war against, to the extent that healthcare is seen as a public good, as a right, and to push countries towards the US model of healthcare. And
thank you, Sudhar. So now we have concluded with the questions to the panelists. Now the floor is open. I have noticed that there are a few questions already answered at the question answer session. But the floor is open. Those who have, there are also some discussions happened in the chat, like, for example, Bill has put, citing the 2018 targets and saying that the mortality target actually went up when we reached here, than it was, going below the target. It went, beyond the target. So this kind of discussions are also happening. So I encourage everybody to look at the chat also here. But the floor is open for the question answer session. So we are running a bit late, but still we can, I think, take another 10 to 15 minutes. And please raise your hands, and then we can open the mic for you. I don't see any hands. Yeah, there is one. Yeah, please take Lizzie. Please, you can unmute yourself and.
Great, thank you. Just a quick one. I mean, I like the conversation, but after the Trump administration was trying to lean on private sector investments to close the gaps in the global south. But I think the last speaker just mentioned we need to be a bit realistic in calling out the private sector to invest more in the health space. So I just had to clarify, Does that mean we don't go the private sector way, or we don't look at blended financing? What was her initial thoughts in her input?
Yeah. Any quick response, Sundar?
See, the point is in terms of preventive, promotive, in the spirit of primary healthcare, if that is the concept, there is a supplementary role that private sector plays and can usefully play to be able to close critical gaps. Other than that, there are countries which act on a universal single-payer system, national health model, where there is a very high degree of regulation of the private sector, where in sense the private sector acts under a publicly administered system of prices, qualities, and provision of care. So they are universal systems where you have a single payer which actually determines the thing. Therein, a private sector acts in alignment with public health goals as different from commercial goals. It's not a great solution, but it works reasonably well where a system can, like the Japanese, have a fairly thick. But the Japanese also have a law that you cannot repatriate profits from the health sector to, you cannot make profits and repatriate it back to countries, or you cannot make profits on it at all. So in some sense, in an atmosphere where you are able to keep market forces from being the determination of clinical decision-making and healthcare provision, you are able to actually engage the private sector. But where it is market mechanisms, then market mechanisms really don't work for healthcare system, and you're really going to always be in a mess. So to the extent you can engage the private sector outside and permit it from the market, or sort of make it an extension of the publicly administered services, there is some scope. There is a considerable scope. This is very difficult in third world countries because governance has its own set of problems here.
Gopa?
Thank you. Yeah, can we just take up Bill's hand is up, so then we can sort of respond to Bill.
Can't see him. Yeah, I can see his
Bill.
hand.
Yeah, please. You can unmute.
Yeah, hear me. I don't know if you can hear me.
Just about.
Yes, we can hear.
Oh, okay. Yeah, I'm just curious what people think about this new initiative that's called, I think it's called Here CSOs. It's some kind of initiative to rethink the global health architecture. That's the way they put it, and to make civil society organizations play a more prominent role in it. I definitely felt sidelined as a CSO representative at this recent high-level meeting on NCDs. You know, we got a joint statement endorsed by 344 organizations, and we couldn't get an opportunity to address our concerns during the stakeholder meetings, which I found deeply problematic. But the thing about this HERE initiative is the global health architecture is it's funded by the Wellcome Trust. I don't have any particular experience with them, but I understand that they're funded by a lot of companies that are for-profit companies in the health sector, and I just wonder if you know my concerns about them are valid.
Yeah.
Okay.
Yeah, Patty, would like to.
Okay. A lot of people are looking to the Wellcome Trust, and as you know, I've forgotten his name, escapes me, but he's really high up at WHO now, doing a massive job. Jeremy Farrar was from Wellcome Trust. I think it's their investments in. I know they invest in a little bit in Nestle, and I'd never known, and I felt they were moving towards public-private partnerships. But people here are trying to think, oh yeah, we should really. Like we have the Bloomberg philanthropies are doing all sorts of things in NCDs. And I'm not sure, I don't want to speak out of turn here, whether Wellcome will go down the same line or not. the conflicts of interest do bother me, and so IPFAN has never applied to them, but I know many people do and like them. But I personally, it's so big. It's so your question is quite right. It's, you know, we're not being heard properly, or we're being consulted out. Sometimes I feel they're asking us, and do what we say actually make any difference? We need to make sure that it is actually properly acted on. And to me, it seems as if there's such a conflict in the heart of every government that well, certainly I work with the UK government, and this growth strategy is so taking over everything. So, you know, that health plan that I was talking to you about is mixing up prevention with growth in the document. And I'm thinking, this is just crazy. You can't, you know, we've always had preventive health. It's not the same. And so then they're trying to sort of relook at the corporates in a different way and say you can make money out of it. But of course, we do have these obesity drugs now. We have all sorts of, and the tobacco industry is now saying the vaping is going to help people. You know, so there is this duality of thinking in people that actually you can make a huge amount of money out of preventive care. And I think it's something that we all need to get our heads around, but also sympathize is the wrong word, but understand that it has always been the case that there is a conflict. The general public want your government to grow and have a big marketplace. When we were in the EU, that's what the EU wanted. We're now in Britain, but Britain wants to grow its market, and it sees that's the only way out. And so are we saying no, don't? Or what, or are we trying to guide them to make sure that they don't do stupid things like get all the education done by the corporates who are making money out of it? To me, the education is absolutely key. The communication to the public. These corporates are actually setting the scene with the digital marketing and everything. We know, we follow it on the baby milk, but it's on so many others, that people are going to the digital social marketing rather than to their doctors, rather than to our wonderful NHS. They're seeing stuff on the phone much better for them, and they'll just go straight for a very, very you know, expensive and probably dodgy solution to their problems. But I don't know. This is a big question, and when you factor in the US pressure, it's all huge. So I don't know whether I've answered your question, Bill, but I would like, obviously, our the true non-profits who are working for public health to be listened to more. I certainly think in our infant feeding, WHO has certainly done that. I can see a massive change. Same UNICEF, massively changed. UNICEF doesn't take any money now from ultra-processed foods companies. I mean, that is a massive change, because these agencies were funded often by chocolate manufacturers. That nobody thought anything of it in the 80s, 90s. That's what you did. So they have had to change and shift, and I think we have to show a little bit of sympathy of how long that takes, and just be firm that this is not the right way to go. Okay, and that image transfer from the UN to the corporates is very powerful and very confusing for the general public to understand who they should listen to. And, you know,
Thank you.
I'm going to hang on in there with UNESCO to see if they can end their partnership with Nestle, and maybe they will. Okay.
Thank you. Yeah.
There is a question in the box. Okay. Do you think there is hope for the US to join back the WHO and to have additional countries provide increased financial support to the US? I actually had a discussion with some people who are in diplomacy in the Indian context. Their sense is that the WHO, the US still manages, despite not being formally there, through a set of proxies, as you can see in those who have endorsed and not endorsed the international health regulations, to get its viewpoint across. So this question of joining or not joining, they have done this before historically. They have left and they have come back, will change with the American politics. But what I think we need to learn is the real core of American capitalism, where the heart of it, where it stands. And we shouldn't forget that lesson where we are with Prom or not. The other question is more tricky. Why aren't the other countries standing up? I really think this is an area for civil society to see what it can put its act together, especially with the expanded BRICS formation. The BRICS was not made as a political formation, unlike the non-aligned movement of Europe. But thanks to Trump, it has become one. Okay, and we should look at seize the moment and see what we can really do. I think we have a fair degree of influence within the 20 odd countries. It's no longer just 5 countries, another 20 countries are joining it. We can really do to expand the scope, and other countries are interested in it, and we do need to think about something on that. And then there's the first question that on regulation, Gopa, that you may want to answer yourself.
Yeah, but before that, I think I just want to, I don't see any hands at this moment, but I would like to add this Novo Foundation and the WHO Foundation. And WHO has received money from Novo Foundation, which I'll all urge you to look at the paper published recently by the UN University on foundation, and according to that paper, it's a private foundation. So in that context, I think, Nicoletta, probably you can quickly respond to this, what kind of threat which is coming, and also this, how the WHO is basically responding to this withdrawal of US. Is it, every crisis offers an opportunity to correct yourself, but it also gives an opportunity to go further worse. So which direction it's also going, so you can respond it very quickly.
Thank you, Gopa. I would like just to responding to Bill. I just will say, first of all, that I have not I'm not conversant very in depth with this Wellcome Trust initiative. But what I can say, having studied quite a bit foundations, this kind of corporate variant that actually is philanthrocapitalism, and all the private foundations that move around it, I think we can easily talk about a very compacted echo chamber of power that connects entities with each other, and entities, private entities, with institutions. That's why I think we need, first of all, to make a very clear semantic distinction of what it is an institution and what is not an institution, even if it has institutional power, because otherwise we play their game. So I'm not surprised now that the Wellcome Trust, whose director, by the way, has now become, after COVID, the chief scientist of the WHO, just to give a sense of this echo chamber compacted system. That, I mean, yeah, it's a system of power, is now, of course, understanding that what is happening with Trump, what is happening with this edifice collapsing after 8 years, not just the WHO. It's, the financial cuts will either reduce the number of the agencies, it will be merging agencies with each other. So it will be a complete, perhaps there will be a substantial redefinition of the UN as we have known it for 8 years. They are capturing this opportunity to control it. So now they have all the power and the money and the people and the, the various actors of power that can create the new scene, where we, as Bill, you were saying, and I mean, I'm not surprised, we are increasingly losing ground, because there is also a form of substitution of the so-called civil society, not just the NGOs financed by the big, companies, but also by the big philanthropic capitalist foundations, and the new ones coming, like the Novo Nordisk. I think we are in a shifting moment. My kind of my feeling is that after COVID, in a post-COVID time, only 5 years after this big emergency, we are definitely shifting from what used to be a corporate capture into what is a real corporate governance, which is a system of institutionalization of entities that are private entities and also financialized entities and really unregulated. And that is what really worries me, because, you know, you have the free riding in a system where there is no regulation of even these giant actors. It's not just the TNCs. It is these new bodies that are cells coming out of the organism of TNCs. And it's a plurality and multiplicity of entities of different kinds and different formats, and new ones will come. So I'm really concerned that, we are at a transition time where we are still very separated. I mean, yesterday the World Bank was talking about the fact that we should get out of projects. We should, stop the projectification of health policies, food policies. Come off it. They say it before us, and we should. We have been on projects for too long. I think we know we really need to go back to political economy of things, policies rather than projects, and perhaps even go under track and really think strong about a completely new narrative, a completely new analysis, completely new interpretative tools to understand this reality where diplomacy is gone. I mean, with the Gaza agreement, it's clear that any multilateral diplomatic effort is gone, because you have one who sets the round rules for a diplomatic agreement, so-called, for a peace agreement, which is basically something else. And it actually, threatens you that if you don't agree, war will continue. And I think this is really a major thing. The WHO has been in crisis for a long time. I mean, I'm not really nostalgic of this WHO, completely in the hands of this private sector. I think the WHO could be doing so much more if it actually reclaimed the notions of health as in Alma Ata, as in the real, ground rules that the WHO was able to elaborate in the 70s. It would cost less, it would be so much more effective, because as Bill mentioned it, targets are going up. No matter how much money you put into it, if you put the money in the wrong way, the targets will continue to go up, which is exactly what has been happening with all these Millennium Development Goals, especially with the Sustainable Development Goals. Nothing going in the right direction with the Sustainable Development Goals. And all this money, I mean, and I finalize here, on the one hand, as we've said, it's all a kind of a generic, out of the moon literary narrative, okay? Promote, you do a little bit, no engagement whatsoever. On the other hand, there is a kind of a contradiction, linguistic contradiction even in the text, because then you have numbers, figures, deadlines, indicators, outputs. This is all language that doesn't belong to health. Health doesn't work like this. If you do the right policies, then you will have the right numbers, the right indicators, the right outcomes. But this cannot be measured in those lists of numbers, which is precisely the corporate culture enshrined in the health debates. This is not going to function. I'm sorry. If you just glue the corporate logic into the health policies, you are just combining two completely different arenas, and it doesn't work. So much money has been spent on health in the last decades, and yet the conditions of health of people are not overall projected to improve. They are not, because health is not just one disease. It's a much broader concept of well-being, of being in harmony with you, with your people, with your families, in your work, in nature. Look at where we are. It's exploding. Health is exploding. It's totally exploding. And with technology now, of course, we will have to deal with technology, but this idea of a further personalizing, individualizing, technicalizing health is going to be hell, as far as I kind of imagine. Very costly.
Thank you, Nicoletta. So we have overshot time, 15 minutes, but still, I think considerable number of participants are here. It shows some interest. I'll give just 1 minute each. Any closing remarks by the or reflections by the panelists, so we can start from this time right to left. So not politically, but but I'm saying right in the sense like right side of mine, and that's actually left side of the screen. Fran, from Fran, then Sundar, Patty, and Nicoletta, then we can close the.
Okay, I'll be really quickly because it's gone midnight in Australia, so I'm just about awake. But the declaration talks about reaching the furthest behind first. I think it should talk about pulling the furthest ahead back more. You know, we need to not just focus on poor people, the disadvantaged, but look at the privilege, look at the rich, and look at what we do about that. And that includes all the things we've been talking about in terms of corporations. And as Patty says, that they maybe have a role, I'm not sure, but if they do, it's certainly not being part of our health policy or defining what we do about non-communicable diseases. So I think we really need a much broader attack on how do we create healthy societies, and rather than NDCs. And I'm very worried that the private sector will just see it as another place where they can extract more profit from. And I think that's the big danger that we're facing.
Sundar.
I think we've said much of what needs to be said, but I think what we need to think through is how people's health movements and allied organizations should react to it beyond this. Should we place an alternative declaration? Then we sometimes place it very far ahead of our times. But at some point, should we think of things they could have done better? Should we be writing to countries into positions they can take? How do we mobilize what we feel? How do we take it to a larger number of people, the problems that are happening and what it reflects? So while this helps build our understanding on the issues, I think we need to think also on ways we can take this forward. But otherwise, I think we've covered this quite extensively. Thank you.
Yeah.
Patty?
Me next? Okay. I just very briefly, I mean, I'm very torn and totally take what Nicoletta's saying, but I'm nervous about pushing for a reconstruction of everything because I see the companies coming in. I mean, we've known that the World Economic Forum has always wanted this multilateral approach. And so this, I mean, now the WHO is going to be having
multi-stakeholder.
Sorry? The German
multi-stakeholder.
Yeah, the multi-stakeholder, but you know that they have this thing in Germany now, the World Health Forum, that we fought and I thought we'd got rid of it. They started it in Moscow and now it's happening every year. So I don't want to destroy it until we have something else, and maybe we can't have something else unless, but I want to stay true to actually the WHO constitution and all those different things. I think they have amazing things in them, and we just need to get them to stay focused on it. I was talking to a WHO person the other day, and I don't think he'd looked at it for ages. He was saying, it is amazing. Health for all. It's fabulous things in it. Let's promote that and make sure that all those UN agencies remember that and don't get knocked off course by Trump and everything. We've been used to the US damaging everything. I mean, the last resolution we got through, just the US was out of the room. And actually we got through regulation and all sorts of things about conflicts of interest and keeping policy setting, only because they didn't mess with it, you know. And all of my career within this has always been that the US has been problematic, but it would be good to have global consensus. And that's what Trump and the others know. They want to destroy that global consensus. I really value the global consensus. So even if the US was in, I think it would be better because we would then have some control because I don't know, maybe I'm being naive, but we have got quite a lot through sometimes. All right. I don't know the answer to that. But destroying
Nicoletta.
the whole thing to me is too much, really.
Yeah.
Okay.
I want to reassure Patty that I have no intention to actually get rid of the WHO. In fact, I was advocating for the opposite, to get the WHO do its work again, which is not exactly what it always does now. Okay, so and I don't want to be nostalgic of the past. I think also institutions need to adapt and change because, like every organism, they change. They are in different, in different contexts now than when they were created. But I think you have to go back to the basics. And I don't believe that this WHO is able to even remember. You don't have the people who even know the political culture that was around the basics, Alma Ata, and many of the things that the organization performed in the past. Of course, I don't want to look at the past. I want to look at the future, but the past is necessary to build the future because health is health. I mean, health was the first institutionalized and constitutionalized right in the history of humanity. It was the first binding right. There must be a reason for this. Health is a glue. Health is a lens through which you look at society, the quality of democracy, equity. You look at solidarity, cooperation, all the things that are now seem to be, under attack. So I do cherish health as a lens for human rights and for planetary rights just as well. Health is the health, not just the human health, but health of the planet. I think they're also interconnected. But in order to achieve this, I think we have to be bold. We have to get out of our comfort zones. And perhaps, out of this webinar, also taking back a little bit what Sundaram was saying, maybe not just necessarily a declaration, because, a declaration has never really saved the world. But perhaps we should ask, for example, the WHO to insert a certain industrial sector related to NCDs in their blacklist. Let's start to, expand this blacklist, which is so pathetic now. Tobacco and arms, of course, obvious, but the very bare minimum. So if you don't expand the regulations and the blacklisting from these people, well, I think we can have so many webinars, but we don't get very far because the political culture of today is the wrong one for health.
So thank you for all the speakers. So what is coming out broadly are the following things when I sort of try to sum it up. Though it's like I put everything in very broad, glossy language, but it does not provide any way to achieve those goals or the targets. And second, what's the reason behind that is actually the political economy analysis shows us that it is the corporate interest and the interest of the developed countries are actually hiding behind this loose language and loose targets. And thirdly, what is coming out is that of course, the Trump and the Trump policies have huge impact, but at the same time, most of the countries, including developed and developing countries, are sort of accepting the status quo, and there is less resistance to push it back, this kind of corporate agenda. And therefore, what have suggested by most of the speakers are like what civil society can do. At least we have the freedom or we have the luxury to articulate an alternative view or what is wrong. I think we need to work towards it, and it's at least two, three actionable points came out from here is like looking at all these various editions of this political declaration starting from 2011. Now this is the fourth one, and look at as Bill has shown us that some of the targets which is missing, and the targets even could not achieve. Therefore, I think we need to have a much more collectively looking at it and to bring out in the public domain these fallacies around these 4 editions of declaration. And another one is that looking at focusing on WHO, because it is one of the important organizations to carry forward this work. And it's in a crisis, and therefore this question of blacklisting which has come up on the WHO Foundation, and also to maybe write a letter to the WHO again. This is the time to People Health Movement once wrote in 2015 a letter during the Ebola crisis, signed by a large number of people. Similarly, I think it's a time to respond to WHO to critically look at some of these reforms and its impact in the coming days on advancing the public health. For instance, like taking money from Novo, or even and WHO, which have no permanent staff. So that means no institutional memory, or bringing the organization to the risk of people without any kind of commitment to the cause and the organization. A person joined in the WHO will be searching for the job for the next job from the day one onwards, instead of investing the time and building the capabilities. So I think these are some of the issues I think we need to look at it. And this webinar, we did not look at the issues related to the medicines on NCD. It's a big issue. And similarly, the last part of the declaration, which deals with the data and surveillance. Again, this may even in a way furthering the corporate interest on data mining and data capturing. So I think these issues also needs attention in the coming days. And lastly, WHO's essential medicine list came up a few weeks ago. One of the medicine is listed is Keytruda. That's the top selling medicine. And one vial costs $2,600. As per the market rate, that's a MRP. And if 80% of the facilities, 80% of the essential medicines to be available as part of the target, then I think these are the kind of prices we are talking about. And let me stop it here, and thank you once again for joining this webinar, and thank you for all the panelists and participants. Thanks.
Thanks.
Thank you, Gopa. Thank you very much.
Thank
Thank
you.
you, everyone.
Thank you,
Saying
Gopa.
very wise
A
And
comments.
lot of resources were listed here. People have put even on blended finance and other things. I think you can click and look at that and take it, as part of
Very
your
nice.
reading list.
And
Thank
we
you.
will share.
Bye-bye.
Bye.
Bye-bye.
Bye. Bye. Bye.